Welcome everyone to the IFS Down Under podcast, where we have deep conversations with leaders in the IFS space and share stories and the wisdom of Australian IFS therapists. I'm your host, Oliver Brook, and I'm here today with my co-host, Lorani Lees. Welcome, Lorani. It's always wonderful to be with you. Thanks for coming on again. Yeah.
Yes, thank you, Ollie. I'm delighted to be here again. And of course, with Adele. Thank you so much, Adele. I think the last time I saw you was in 2023 when I did your course, Pain Explained. So super excited that you're here and I can ask you more questions. So welcome.
Yeah. And that's really wonderful that you've got that connection. Yeah, and Adele and I think we met on our level 2 with C. Sykes. Yeah, might have been in the same year actually, 2023 as well. Yeah. So we'll get into all of that. But just before and how I want to open this space is I want to do an acknowledgement of country. And so I want to acknowledge the traditional custodians of the land on which I'm presenting, which is the Whadjuk people of the Noongar Nation, and those across Australia, especially the places and the lands on which Lorani and Adele are currently on. And I want to acknowledge the systemic impact that colonisation has had on First Nations people and the impact on their elders, their healers, their languages, their practices, their culture, and also the adaptive survival and the protection of language, culture, children, and ways of healing, and the beautiful nurturing of our land and our country, and also the ancestors that went before them and before us as a group as well. And I'd also like to acknowledge each of your ancestors that are in line before each of you, Lorani and Adele and mine, and how all of this kind of makes up Australia, these different lineages, these different histories. Pay my deepest respects to those ancestors of the First Nations people and our own ancestors. Yeah. So, Lorani, would you like to, introduce Adele?
Yes, it's my complete pleasure. So hello, Adele. I'm just going to read out yours, a little bio about you, and just checking with your parts as I read this out. Yeah. So, like I said, the last time I saw Adele, I did her course, Pain Explained. It was an amazing course. I learned so much, reinforcing what I've learned, but also really important things that I was not aware of. So, Adele, thank you for coming. So, what's really struck me in this IFS community that we have here is that we have so much talent, so much knowledge and wealth and wisdom. And Adele is one of those that's in our community that just offers so much and with so much generosity in her offering. So, Dr. Adele Stewart has been a GP in the Illawarra region since the early 1990s. She was the 5th GP ever in Australia to receive recognition by the Royal Australian College of General Practitioners. She has extensive skills in psychological medicine. She is a level 2 trained IFS therapist. She's currently the chair of the Royal Australian College of General Practice with a particular special interest in pain management. She has a special interest in pain neuroscience, the mind and body aspects of chronic pain and complex trauma. So in amongst all of that, Adele is also a certified mindfulness-based stress reduction and mindful self-compassion teacher. I don't know where you find the time, Adele. In 2024, Tim Goddard from the Openground and Adele co-created a course combining pain science and mindfulness. It's called Pain to Peace. So when it comes to teaching mindfulness, explaining pain, Adele knows it all, and now she has this knowledge and wisdom of IFS. So combining all of that, also such a rich combination of knowledge and wisdom. So Adele, thank you for coming on, sharing with us, and we look forward to asking you lots of questions.
Oh, thanks, Lorraine. And of course, the negativity bias. I just got caught up on where I was recognized by the RACGP, the fifth GP. I was the fifth GP recognized to have extended psychological skills, not the fifth GP to be recognized.
Yeah.
Thank you. Yeah, well, that's just doing a massive achievement.
Yeah.
And yeah, so thank you so much for having me. It really is. It's really lovely to have been asked. Thank you.
Yeah, welcome. It's wonderful to have you, and yeah, thanks for clarifying that one. Yeah.
So maybe Adele, just following on from that, so your area of interest has been psychological medicine, has been pain, and most recently, because I think you and I met in the level one when you did your level one, and you really stood out with your understanding of the body and pain and IFS. So how did you come across IFS, and what resonated with you personally and professionally?
Yeah, so I mean, for the first sort of 20 years, I was just a very standard GP, and I loved it. I was a real workaholic, and I couldn't imagine doing anything else. Um, but then, around about 10 years ago, at a time when my son was going really badly off the rails with drugs and mental health problems, which I can now thank him for because it kind of opened my mind so much to looking for other things. And I first went down the sort of mindfulness route. Um, and you can probably tell from my bio that when I get interested in something, I then want to teach it. So, I went quickly into that. And then I discovered ACT therapy, which was my sort of mode of therapy. And I loved that because of the mindfulness element. And it was actually the mindfulness teachers at Openground, so Tim Goddard, who you mentioned in my bio, and friends who got crazy about IFS. And I just trusted them because, I just do. So I sort of looked into it, and when I was looking into it, it happened to be right at the beginning of COVID where we went into the lockdown. So the first training, instead of it being live, went online. So I got a place on it, not realizing later how lucky I was. I was just like, oh yeah, great, signed up. And then yeah, when I went, it was like, wow. It was just like, this is like mindfulness, self-compassion, all the embodiment therapies, the bits I like about ACT therapy, all like so beautiful. I loved the I loved the sort of capital S self because I felt like it gave me a bit more of a credible way of talking about these states I'd touched on now in meditation and retreats and things, but sound a bit woo when you're talking, professionally. So, the concept of self in IFS was really helpful. But probably the thing that actually resonated most and helped most is the befriending all parts are welcome. Like at first it was just like, oh yeah, all parts are welcome, blah, blah, blah. But over the years, that is the piece that has, I think, transformed me and a lot of what I do with people. Yeah.
Yeah, yeah. And that piece there, the befriending and the the unconditional welcoming of parts. Adele, like, um, can you expand from that? Like, how from that perspective, how has that changed in terms of the relationship that you see with chronic pain, or
Um,
how has it?
so I guess like I have a personal history of chronic pain, not surprisingly, and complex trauma. So many of us do go into this kind of thing. actually interesting, by the time all this happened, my pain had, by the time I came across IFS, my pain had pretty much resolved, or I like to say it's 97% resolved. But I did not like my pain, surprisingly. And I perceived it as just such a kind of a failure, as shame, that I couldn't do sometimes the long shifts that other doctors did and that sort of stuff. And it was not an instant thing, but as I sort of discovered parts of me that were people pleasing and desperately, and you can tell by my bio, constantly trying to fix myself and others, and sort of perfectionist streaks. I got to know my pain and my history was fibromyalgia as a part that was it the only way that would get me to rest. Um,
Mm.
so so these days I I still get it, but only a little bit. And I get it, and it's like, so in that consult where my pain started to come up at the end, where was I, trying to fix that person? Where was I instead of being self-led? Where were those parts coming in that were, I've got to fix them, I've got to fix them. Um, so yeah, I guess I'm using myself as an example.
Mm.
And yeah, and it obviously applies to others as well. Yeah.
Mm. Yeah, yeah, yeah. Were there any other key moments, Adele, or turning points in your career that shaped your perspective of chronic pain?
Yes, so in discovering what you kind of discovered in my course, which I call Pain Explained, so the Noi group, Lorimer Mosley and David Butler, which a lot of people will have heard of, have the explain pain model, and that was really quite mind-blowing. And ever since, so it's almost like actually my discovery of the what I call the modern pain neuroscience and IFS came actually a very similar time. So they have kind of, it was really good preparing for this interview and thinking about things actually, because I don't really reflect very much. I just go like a bull at a gate, really. But to sit back and reflect, it was like, oh yeah, the pain and the IFS piece did. There's a real sort of confluence of them arising at the same time, and it's like the pain neuroscience was like, whoa, and then the I didn't sort of go, oh, IFSS, we're great for working with pain. It was a sort of slow burn of how IFS you can work with any parts, including pain, which obviously we'll talk more about. And just realizing how in the last even couple of years, how much they're sort of traveling together now.
Mm.
Yeah.
Yeah, yeah. That's amazing. And it's so interesting to hear that for me and my system because it does seem that there's a whole bunch of different modalities and areas of psychological science at the moment that are all kind of heading in the same direction. And IFS is kind of one of them, and neuroscience is another, and mindfulness based stress reduction is another. And they're all kind of meeting at these different points. So it's really nice to hear that your journey has been kind of coming up in those three places and others, and that and some of them are coming together. Yeah, I guess I wonder then, like, what led you to deciding to integrate IFS into working with pain? Was there kind of a point where you realized that they did work so well together, and maybe you could kind of speak to that? That's right. Yeah.
Think it was more of a organic process.
Mm.
So firstly, I was getting like, okay, going back to 10 years ago, I lived 100% in my head. Like I knew about the mind-body connection. I used to even talk about it to people, but in retrospect, had I very, very little connection to my body. So before I came, I think if I'd come to IFS at that point, I'm not sure how it would have gone for me actually. But because I came to it after having done a lot of mindfulness and meditation, I was starting to connect to my body more. I was starting to work with people's emotional pain in their body a lot. And when you think about it, there's not a huge difference between um, emotional pain and physical pain. I mean, of course there is, but when you're working with them in a psychological way, they really are very, very similar. Um, and the learning probably more in the pain neuroscience how complex pain is. And I think in one of the talks I heard you with someone else, Ollie, I think I heard you use the word that complex emergent system. And so that's a really big concept that we'd call the mind that, we'd call parts that, but also pain is very much a complex emergent system, which means that there's lots of ways in. So like with acute pain, I mean, a lot of the IFS and pain neuroscience can apply to acute pain, but it's probably more useful just to go into it from a kind of bio tissue basis. But once the pain's been there for a while, and this is one of the misconceptions I help people correct, is chronic pain's not just acute pain that's kept on going. Chronic pain is an entity where there's a whole lot of other neuroscience kind of processes and going on in the system. And then there's so many ways of going in. So we still might go in with the what I would call in the medical field like the peripheral drivers, things going on in the tissues. So it's not like we're saying you never have surgery, or you never have cortisone, you never have medications. But to point out that that's just a tiny, tiny piece. And IFS with its metaphor, and it is a metaphor, even though a lot of us IFS people talk about it as though it's literal, it is still metaphorical at a level. The metaphor of protectors is just so useful because pain, we even one of the neuroscience concepts is that pain is a protective buffer. And so
Mm.
especially once you've got chronic pain, the pain neuroscience doesn't view pain as a marker of tissue damage anymore. It recognizes it's a protective buffer. So
Mm.
immediately imagine people listening are going to, oh, protector, protector. So
Mm.
this metaphor of pain as a protector um, is just a really wonderful way in. Yeah.
Yeah. Yeah, so many things there, Adele, I want to kind of pull apart, and I'm also aware of the question that I was going to ask. But yeah, something there you said. So there's acute pain, which is in our tissues, right? Either an injury or something that physically happened to us in our body that might be causing some inflammation or hurt, and then that can be acute pain. Is that I'm hearing that right? And then chronic pain is this
I'll pause you there
complex.
though.
Oh yeah, pause. Yeah, go
I'll
ahead. Yeah,
pause you there because it's a really
yeah,
important point in
yeah.
everything's right, except for the very bit at the start when you said pain is in the tissues or pain is
Oh
in the
yeah,
part of the body. So
yeah, yeah.
even with acute pain, we now conceptualize
Mm,
pain as being produced by the whole system. So I talk about the
mm.
the the whole neuroendocrine immune system is
Wow.
producing the pain. Having said that, the rest of what you said is right. Yeah, like the
Yeah.
the bits and bobs that are happening in that body part,
Mm,
probably the actual injury, the inflammation is probably more important. While as you go more into the kind of chronic pain area,
yeah.
the whole that's brain, nervous system, endocrine, all the stress,
Yeah.
adrenaline, cortisol, and the immune system, it's got so much more of a link than we've ever thought with the nervous system that all
Wow.
that becomes much more important.
Yeah. And so that's when you talked about the complex emergent system. That's all of those systems are relating or are part of the experience of having pain in the system. Yeah.
Yeah, yeah,
Yeah.
yeah.
And so what would an IFS informed kind of pain consultation look like? Like how would that differ from traditional biomedical care around around this? Yeah,
Um,
what's changed in your practice around now being IFS informed with pain?
So for me personally, a lot of people will come to me for 1 or 2 sessions just to get a kind of taste of things and decide where to go next. So a lot of the new people I see, unless they come in with I want to do some IFS, I've got pain, I want to do some IFS, I kind of will play it by ear much more, like, hear the person's story, that look, I think actually another thing that's so important to say is this, because as we talk about some of this, it can start to sound like we're saying that the pain's in your head. So this is a
Mm.
vital concept, is that it is absolutely not in your head, that chronic pain is absolutely real, that if you feel pain, you have pain. No felt pain is imaginary, and no health professional, including myself, can tell you if you've got pain or not. Like,
Mm.
doctors and allied health may be able to tell you what x-rays show or what is going on in your body and your tissues, but they can't tell you whether you've got pain. So to really, that bit is important, I think, for listeners as well, like validating that pain is real. And I'll sometimes and sit there and say to someone, your pain's probably worse than somebody else who's has got, some other comparative condition, because you've got all this other stuff feeding into it now. That doesn't mean we can't do anything about it, but that real validation of if you feel pain, you've got pain. So
Mm.
yeah, sorry, I've gone off on a tangent, but that's that sometimes the kind of pain neuroscience concepts are more are really important before we even go there with something like IFS. Um, and I often get people to look at my modules, because people that are kind of open to that and then will come in are much easier to work with than people who come in for an hour's consult for their sore hip, and they're just looking at me like I've got two heads when I start to talk about any of this, and it's probably not a
Mm.
great use of my time. But I guess that's more me. So in
Yeah.
people who are coming in with pain in general, to give you an idea, I might just, maybe after about 40, 45 minutes, I might just say, if it feels appropriate, um, do you want to have a little try of the kind of work that I do? I don't always even call it IFS. Um, and if and the first thing I'll do is say, do you want to see how it is to go inward or close your eyes? And then I'll go into a little bit of like, how safe does it feel? So, and sometimes a person might immediately open their eyes and say, oh yeah, there's that, it doesn't feel good or something like that. And I wouldn't push it at all. But if somebody's, feels safe enough, I might just do, 10 or 15 minutes light IFS, I call it, on protectors. And
Mm.
sometimes that just, people find that really fascinating, and they're like, I want more.
Yeah.
And less often than I would think, people are like, what the hell? But I'm always surprised how well it's received, actually. So
Yeah.
that's that. And that's kind of different to an IFS pain consult, which is probably not much different to any other. Um, I would just start with the pain as a part, or it might be that the pain's there, but there's other parts that are much more prominent, like anxiety or whatever else is going on in the person. Does
Yeah.
that kind of answer the question?
Yeah, it does. And we're gonna ask some follow-ups. Yeah, absolutely. Thank you for sharing that.
Yeah, yeah. There's so much there, Adele, that my kind of like my interest is like spreading everywhere, and I'm going to try to be more disciplined and just try to stick to this. Um, yeah, Adele, one of the things that really stood out for me with what you just shared, and even when I was doing your course, is that real sense of not you validating. The first time I really heard someone really validating the physical pain, the chronic pain, and it's likened to, when we're doing our work and when clients say, oh, I'm not sure if it's true. I'm not sure if this really happened. And most 99% of times, like, it doesn't really matter whether it's true or not. But what we are seeing, what we know, what is real, what is that you are feeling it right now. The pain is real because you are feeling it. The emotional truth of it is real. And that in itself is it's so validating. That's what you are really reinforcing what you just said before,
Yeah.
about
And
the
I mean,
truth.
maybe even I would avoid the word true if I was doing that. I'd maybe say factual. That's maybe me being iffy with words, because to me, true is kind of more, self-led. While, yeah, factual, sure, that whatever that person's emotional pain has emerged from may not be remembered correctly. And yeah, you can kind of equate pain to that, because pain is not a thing in you. It's an output. It's a subjective human experience. It's a complex system that emerges from a being that's embedded in the world. So it's not a it's not a factual thing. It is an output, or a process. Yeah, and that's not always easy to get across to patients, of course. And that's where I think the mindfulness and pain courses are really helpful, because there's a much more of a sort of felt sense of the truth of that.
Yes, yes. That's about the experience of it, the subjective experience that is so palpable. Um,
Yes, yes, yes. Yeah.
yeah. So in line with that, how do you find how do parts show up in this context? Like when you see, people living with chronic pain, you mentioned about the protectors. So from your perspective, Adele, like how do parts show up in chronic pain?
Okay, so there's so many parts, and so many of them are just any parts. So I've actually got a list here.
Mhm.
I've written down. So I've got frightened avoidant parts, and they can often be protective parts that hold particular beliefs about pain, and often beliefs around things like tissue damage equals pain. Like, I've got a bulging disc in my back, therefore that's what's causing the pain. So parts that can have these kind of beliefs, it can obviously hold a lot of fear and also a lot of avoidance, which then perpetuates the pain cycle. So whatever the pain was in the first place, if we're doing less, withdrawing from life, moving less, then that's going to make the pain worse. Um, Inner critics, like I was mentioning about my fibromyalgia, like I'm in, that's another thing to really get across, is like pain is a part of life. It's not a failure to have pain. And I often use the analogy of, we're not living in a Disney movie where anything that goes wrong is just the aberration before the big happy ending. It's like it is a part of life. Um, and of course, parts that are frustrated with the pain, or angry with the pain, or deny that and dissociate from it. And another part of the pain education is this pain fear cycle, um, which I suppose I touched into with the at the start there with the fright and avoidant part. So it could also be a pain frustration cycle, or a pain anger cycle, or a pain denying cycle, because these things can cause us to go into the sort of boom and bust where we overdo things, or into the fear avoidance where we're underdoing things. And then, lots of firefighters. I mean, a client that I've been seeing for a few years now, when she first came and saw me with her chronic pain, she was ringing up Lifeline sometimes 3 or 4 times per day. So that was a real kind of firefighter part, right?
Mm.
Um, and firefighters that have suicidal ideation. So this in someone, and I do see people with really severe pain. A lot of that's normalizing. I say to people, if I thought I was going to live like that for the rest of my life, I would have a strong suicidal part as well. That is completely normal. So then, of course, it's about giving hope, but also, talking to that suicidal part. What can you do? What can you do for that part? And there is a lot of, might be less in the psychological profession, but with some allied health and doctors, there's a real fear, of suicidal parts, but just to really that differentiation between a suicidal part and somebody who is at great risk of suicide is quite a different thing. And then, of course, firefighters that understandably use alcohol, or use illegal drugs, or overuse legal drugs. And then there's and so I guess all these parts are not pain as the part, they're protector parts that come in, right, around the pain. There's secondary gain parts. So I hate the term secondary gain actually, because it sounds kind of really judgmental. But for me, I had a really strong realization a few years ago when I was the most healthy I've ever been, and that I can ever remember being in my whole life, how it was that the pain of being in the world, like I just didn't have room when I had chronic pain, complex trauma, and was a doctor and a mother. Like there was no room in my life for anything else. So when my health and well-being improved, there was this sense of bloody hell, the world's going to pot here. Um, and my pain came back for a little while. And I had this just really strong sense that this pain was having me retreat again. It was almost a relief. There was a part that was almost relieved that I could retreat from the world. So there's sort of parts that keep us looked after, safely cocooned, perhaps away from possible failure, away from threatening relationships. Yeah, so that's all those. And then I don't know if you want to pause there, or I can also then go into pain itself as a part.
Actually, that was the last
Isn't
question,
it?
Adele. Yes, yes. Please. That was the follow-up question.
Yeah. Yeah, okay. So and okay, so the you can tell there is a part of me that gets very excited about all this stuff, right? I mean, um I could
Yeah.
read about it and talk about it for hours.
They're so
Yes.
welcome here. I'm so glad they're here. Yeah, please do.
Thank you. I do want to also that put out there that we're talking about chronic pain, but so many other symptoms operate in a really similar way. So I'm going to read a list of what I call chronic outputs that could be used in the same frame in both IFS and in the pain neuroscience world. And so
Yeah,
I don't have to say in front of it all. I'm going to say chronic, and then I'm going to list them. So chronic
yeah, yeah,
fatigue, urinary symptoms, tinnitus, shortness of breath, vertigo, pins and needles in the hands and feet, chronic itch, nausea, heartburn, diarrhea, bloating, restless leg syndrome, cramps. So there's probably more that I just quickly whipped that up, but these can all be protector managers or firefighters, right? And can be framed in a really similar way. They are they are real. You feel them, so they're real. They are whole endocrine immune ensemble productions. They are complex emergent systems. Yeah.
yeah,
Um, so pain as an exile. So I have the one I was saying that called Lifeline, and she's given me all the people I talk about are giving me permission to not use their names, of course, but use bits of their cases. So this woman that I call Glenda, she was finding that she had really severe rib pain that she described it was like 1,000 arrows going in and out. And that's a whole other interesting section in the pain neuroscience is the use of metaphor. And she would get it basically whenever she would go out. So she was just not going out because she thought she would always think, oh, I've overdone it. what we came to realize during IFS was that this part protected her from virtually every interpersonal interaction. So that's huge, right?
Wow.
So the difference is that she would still go out, but she could recognize that the pain wasn't that she was damaging herself, it was a protector. Now, I'd love to say that we've cured her pain. We haven't. This is deep, deep-seated, loveless childhood stuff. And she's also got very early dementia, so she doesn't really have the cognitive ability to go into the trauma therapy. Yet, what one of the things she said that really stuck with me was at the end of one session, she said, "Oh, my sweet pain that reminds me to stand up for myself." So you can hear that not all of this is about reducing pain. It often does, but this change in relationship. Yeah. And another client that I call James, he came in with long-term chronic back pain, and his pain has reduced to the point that he no longer says he has chronic pain. However, his pain will come up probably when he's with me more than anywhere else, because whenever we go towards an exile, he calls it a pain spike. He has a pain spike. He can be sitting there and we're getting, at first we could only spend about 2 seconds there. We now might be able to spend a few minutes there, and then wham, 9 or 10 out of 10, he's on the floor with severe, severe back pain. So that's like a really marked, it marked protector, right?
Yeah.
What else have I got?
Yeah. So
Yes,
I'm
yes.
just curious about that. So it sounds like those are like protectors that are kind of like pulling a pain lever. They're like they're using the pain to either prevent something or stop going somewhere internally or externally. So it's like a protector's kind of using the complex system that we talked about before and kind of
Yeah.
activating it or pushing on it or something. Yeah.
Yeah, I love that. And in Glenda's case, she probably doesn't have anything in the tissues other than she has a bit of a habitually twisted posture. Hard to know which came first. But James had the usual disc bulge, blah de blah. So whatever his pain started as was a tissue-based thing, but it's like you, as you said, that there's a part that uses the pain. So the pain has gone from being an acute back pain problem, maybe related to the prolapsed disc, even that's arguable, to the pain as it's now, I sometimes say to patients, like, yeah, parts hook onto something and they use pain, or the pain lever would be a great way of describing James's, or just a patient I saw yesterday who has got chronic face pain. And, we don't do a lot of going deep because she's got young children. She has to function, and she's only perhaps just ready to even go there. Now, I mean, I've known this woman since she was 15 and she's 45 now. So, and so she didn't have pain when I met her when she was very young. She's only developed pain in the last few years. But what we recognized just yesterday was that we did some mindfulness, and the pain and tension in her jaw settled right down. And then we kind of just accidentally went there. She had this flash of a little girl exile, and the pain and the tension, it was like, and we're like, okay, so what's that telling you? And it's like, I'm not ready to go there, or this part doesn't think I'm ready to go there anyway. So again, we haven't, there's changes in her pain, but it may be that her parts may use that pain for forever, for a long time, but hopefully, like James, it will become less. Yeah. And very occasionally you might get just to put in a bit of good news, because it is all very subtle and back and forth, 2 steps forward, 1 step back type changes. But occasionally, if you can connect with a protector, often I find if it's changing a faulty belief, you can get this dramatic change in pain. So my most dramatic one was a guy who's both his mother and his grandmother ended up with that very, very severe rheumatoid arthritis, with the really twisted fingers, and his grandma was in a wheelchair. He didn't have rheumatoid arthritis. He just had a back pain problem. Every time his back started hurting, he would have these images of his mother and his grandmother and this deep belief that he was going to end up in a wheelchair. And not so much by IFS, but just doing the pain neuroscience and sort of correcting that faulty belief, his pain stopped. So,
Wow.
like he might get it in different contexts, but that was a kind of dramatic one.
Yeah.
Um,
Yeah.
I guess the other pain as a protector is like my fibro pain that comes in to tell me you're overdoing it with others. You need to rest. And that is really common. Actually, Dick Schwartz has been involved in a little research trial on rheumatoid arthritis. So rheumatoid arthritis is a very, it's a pathological disease process, yet some people, their pain's okay. It really is very manageable. Others, it's not. And the ones that it's not, there really does seem to be very big caregiver parts. So that's often the pattern, is somebody who's over caring, and the pain just stops them so that they can't do that. Yeah.
Mm.
Yeah, Adele, thank you so much. Like, what you're really highlighting on a very kind of big perspective level here is that pain, it's so systemic. There's the systems that surrounding it, the protectors that surrounding it, doing their function, doing what they need to do to either prevent, to avoid, to minimize, and they carry all that protective intention and agendas. Um, and in our culture, we have a culture, a Western culture, where there is that one of the misconception is that if you have pain, if you are injured in some way, the individualistic kind of perspective is that you have done something wrong. There's something that you are not doing, or that's something that you should be doing more. So all this misconception around pain, you really demystify and really just um, go into the nuts of it with neuroscience as well as IFS. From your perspective, and you named a few of the misconceptions, is there any other major misconceptions around chronic pain and pain that you would like to offer?
I think I don't really like the term biopsychosocial model, because my connection with that is being a med student and going, yeah, we all know about psychosocial is important, but tell me about what's happening in the tissues. Tell me about the important stuff. So I don't tend to use that term, and especially not with doctors, because again, they can be quite dismissive. But it's back into that complex system and how many factors can be involved. So if I'm saying to someone that your pain is not coming from your knee, I have to be very careful the way I say that, obviously, because it can, no matter how hard you try, you can sound invalidating. Yes, you have knee arthritis, but knee arthritis is like, it's a whole system thing. This is going a bit more clinical, medical. You've probably heard of that, the low grade inflammation in your system, and that's going to be made worse if you don't eat very well, or if you don't exercise and move very much, if your sleep's poor, and you can probably hear in there how much judgment and shame there could be in that. So it's so important to be saying, and the trouble is, if we're chronically stressed, we actually crave foods that are bad for us. It's not our fault that we crave that. It's not a failure if you eat poorly. So, and of course, there's parts that don't want to move for all sorts of reasons. Like, you don't want to be connected with your body. you're fearful of injury. So again, all these sort of de-shaming kind of factors around it, but the reminders that there are ways in. And I think another thing that I think you liked, Lorraine, was the danger and safety aspect of things too. Like that, a beautiful metaphor, which I think ties really nicely into IFS, is that in some ways the production of pain is a balance of danger and safety in the system. So I think that's another lovely way of bringing in this biopsychosocial. You can work with IFS around, I can be working with someone with IFS and talking about that part being a danger signal, or the hatred that you have for that part being a danger signal. So a lot of the work is around de-threatening. In IFS, we would say parts. In mindfulness, we might say emotions. And of course, de-threatening the pain itself. Because if, like, Glenda now goes to church and gets the pain, but instead of going, oh my God, what have I done? She's like, oh yeah, that's because that minister reminds me of the minister I had when I was 20 and did XYZ. And she can be kind to the pain. So it's still there, but it's becoming less of a danger signal. Or all the other things, and I've just touched on a few of them: diet, stress, movement, sleep, all these other things that obviously sort of psychologists' bread and butter to remind people about lifestyle stuff that can be safety or danger signals in the system. So yeah, I think that there's probably other things. If they come to me, I'll let you know. Yeah.
So yes, it's really pointing back to can we get into relationship with whatever is here?
Yeah.
Yeah. Yeah, thanks so much for sharing about those kind of misconceptions, Adele. And what I'm thinking about, and it actually wasn't part of our questions, but I'm kind of hearing it between what you're saying is there a connection between the level of trauma someone has had, either relational and complex in their childhood, or single incident trauma, and then having more likely having pain conditions? Like, is it that is it similar to the underlying kind of process of, say, depression or anxiety, that the more internal wounding that someone has, and the more likely they'll have a systemic response of depression or anxiety? Is it similar to chronic pain? Is there some connection between the level of exiles?
Yes, absolutely. So, I mean, one thing that it horrifies me that doctors, I don't know if they get taught about it now, but they certainly didn't up until a few years ago, was the ACE study, right? Adverse childhood
Yeah,
experiences. So there's absolute literature that says, I can't remember the statistics off the top of my head, that all sorts of chronic disease is increased, and chronic pain is absolutely increased. And there is a connection. I mean, complex trauma can have someone being basically in a chronically stressed state, and that, we talked about the immune system, that can affect that low grade systemic inflammation, and then there's that vicious spiral of eating worse and exercising worse and having worse relationships and having worse sleep, and there's so many connectors there. But yeah, it's not like a kind of woo thing at all. There is an
yeah,
absolute, it's just not embraced by traditional medical doctors, I think, because it's just too bloody hard. I
yeah,
think that's what puts them off. Yeah.
yeah. And
Yeah.
they're not trained in approaches that can treat it in that more emotionally systemic way, like IFS.
Or they
Yeah,
divide it into, like, this is one of the biggest problems is, oh,
yeah.
that's real pain and this is stress-induced pain.
Okay.
Well, yeah,
Yeah,
I'm sure everybody can hear from our whole conversation how it's nowhere near that, that yes, there's extremes of spectrums, but there is so much in there that is so much more than that. Yeah.
yeah, yeah.
Yeah.
So important, that systemic, much more systemic lens. Yeah. And let's kind of shift towards um, kind of treatment and hope and what is possible. And I know you've co-developed a mindfulness-based stress reduction course, Pain to Peace. And I'm
Yeah.
wondering if that has some IFS in it as well. And yeah, what are some things that you're offering that people could, if someone listening is a therapist that works with people that have, systemic chronic pain in their system, or it's a person that has found this talk because they have pain themselves, like what are some trailheads that they could go down that might support their system that you either offer or, yeah.
Yeah, sure. So firstly, my website is Adele Stewart MBI.com. So MBI stands for Mindfulness-Based Interventions. So everything is on my website.
Yeah.
Probably the simplest and cheapest thing is I offer an audio course, which is a 20-week course where every week a 15-minute, might be slightly shorter, slightly longer, audio of me just talking about one of these topics arrives in your email box. And I also have a WhatsApp group going, so people can interact. And along with that, a recommended meditation that goes with that is accessible by Insight Timer, one of mine. So I call that Mindfulness and Pain Explained with Dr. Adele Stewart audio course. So that's a very palatable option for people who want to sort of dip their toe in. And I run that by donation and people can repeat it if they want. Pain to Peace is MBSR for pain. So for those who don't know, MBSR was originated by John Kabat-Zinn in about 1979, and it's an amazing course. Adding in the neuroscience has really been transforming. And we don't, yeah, I think I probably do mention IFS during the course, but because Tim and I are both IFS trained, then the course certainly has a flavor of parts. And of course, so much of it is about mindfulness and self-compassion as that radical acceptance of what's going on, and then that paradox of if you can radically accept, then you're de-threatening your whole system. So the pain will often reduce. And the very first Pain to Peace course I ran as a trial for someone who's doing some research from Sydney Uni on patients who'd been on a public chronic pain waiting list. Some of these people have been on that waiting list for 18 months. So they were a very, very severely affected group, which actually ironically sometimes helps because if you're kind of desperate, you're more likely to engage in the course and do the practices. Um, there was a small number, maybe 5%, who didn't really engage or dropped out. But the ones that did either had significant reductions in their pain, or that you'll understand this, that significant change in relationship, which can change everything. Like
Yeah.
when I get my pain now, I'm just like, it's almost okay. I mean, it's like it's a sensation and it's telling me something and it's whatever. Um, so you
Yeah.
really can change. I mean, and that again, not to invalidate people who've got that really, really high level pain where using IFS and mindfulness can be not appropriate. Like go and get the medication that you need or do whatever you need to do to get it down to a level where it is a bit more um, manageable. So that's that one. And
Yeah.
then and I run that Pain to Peace, I run it online via Zoom. And the other teacher of that it's not actually Tim, it's a woman named Mandy Mercury, who's a pain coach from Victoria who wants to get on the IFS training. She's wonderful. So if anybody wants to put people onto Openground, the pain course, it's either run by myself or Mandy, and I can't speak highly enough of Mandy.
Yeah.
Um, and the other thing that I'm just trying to finalize this morning before I got onto the interview actually, is that the area in New South Wales of between like the Illawarra and Bega, which is a very big area, an organisation called Grand Pacific Health have got a grant to run pain programs. So I'm going to be running my Pain Explain program that Lorraine did as a 6-week instead of a 5-week course about 3 times over the next 12 months. And it'll be free for patients in the area. And I haven't really worked out that I'm hoping that we'll be able to have others come in as well. And, that might be a kind of by donation thing. So that's not on my website yet, but I'm going to hopefully have that on my website within the next couple of days. And which this might interest some of the listeners, same deal for health professionals. So there's going to be a 4-week course for health professionals, which is a little bit more clinical. The other one's much more aimed at patients who don't have any kind of clinical kind of background. So I think I'm calling that practical pain neuroscience for health professionals. And I've just run that for GPs, which actually I was so nervous about it, I can't tell you. But it actually went really well. So I had about 100 GPs do that, and lots of really, really good feedback. Yeah. I think that's probably about it for what I offer.
Fantastic. That's really wonderful. There's really rich offerings there. Appreciate that.
So generous of you. They are so generous.
Thank you.
Adele, let's just say, hypothetically, if you are, just say, an IFS therapist, haven't had the opportunity to do your courses and had very limited kind of like exposure to pain, but understand enough, what would be one thing that you would want to encourage if you are, IFS therapist in your practice, very new at this, and you have a client that comes in with chronic pain and is in agony, what would be your advice for that therapist?
Firstly, if they're in agony, that's perhaps not the time to be looking at these kinds of things. It's like if you're in agonizing emotional pain, right? If somebody's like deeply, deeply depressed or highly, highly anxious, we want to come up with things that are going to settle their system a little bit, enough that they can do the work. So that would be the first thing. And I guess in that case, if it is agonizing, you need to send them back to their doctor. And this sounds a bit negative, but the only trouble is a lot of doctors are really behind the times with this stuff. So that's where my passion is trying to change the system and trying to educate people. But if we go to somebody who's got chronic pain, who's not in that agony area, and it is important, it's worth saying, I think, that some people, maybe psychologists as well, think of chronic pain as severe pain. It doesn't have to be severe. Chronic means long-term, not severe. And it doesn't have to be there all the time. I mean, thank goodness, most people with chronic pain don't have it there all the time. So that's worth knowing as well. Sorry, I picked up on a word you used there. I guess if I have people contact me, and lots of people do contact me, and one of the skills I think I'm good at is pointing people to from what they tell me, what I think might help. So on my website, the modules that Lorraine is talking about, I do have them there as 5 40-minute videos that are free. And I do think they're worth a go. Like, some people will look at them and it's like, but a lot of people, it just gives them enough of a aha thing. If the psychologists that are listening or the therapists that are listening want to get more educated, then Noi runs the sort of explain pain courses as well. Mine are kind of based on those, but I add in some more mindfulness. They're not, the trouble with Noi is they're not, for some reason, they're not big on the word mindfulness. They kind of mention trauma, but it's sort of like that's the elephant in the room, I think. But the general principles are really helpful. And also perhaps not to be scared of chronic pain. Like if it's been there for ages and the patient says, I've had this done and this done and this done, it's really unlikely that you're missing something terrible. I mean, I get, unfortunately, there's never a 100% guarantee, which makes everybody nervous, but it's safe to be treating people with IFS, with chronic pain, to see what happens. And if it's just not budging, well, yeah, maybe you do send them back to the doctor, and there's no harm in them seeing their trusty physios and osteopaths. So these days we think the hands-on therapy is working more as a safety signal. So another thing that as part of the whole pain neuroscience is to those parts that might think that they're broken or fragile, right? So we're trying to correct those parts faulty beliefs. And so let them know, yeah, go to your osteopath that's got magic hands, but it's probably working as a safety signals to the system. And this is often why the pain relief is just short-lived. It might last for hours or days, but not forever. Um, yeah.
Yeah.
Does that kind of answer your question?
Yeah,
Can
they're
I
wonderful tips
can
to start.
can I jump in there as well, Lorani? Yeah. I what I've been hearing from you as well is this kind of perspective shift for therapists, like as we're sitting with someone. Um, yeah, is to just really validate their experience, that it's real for them, that the truth is happening in them, that it's highly systemic, that there's going to be all these parts that relate to this experience, this systemic experience of pain. And so it sounds like we've got to be kind of broad in how we be with their system, and we've got to be curious about all the different kind of relationships inside, of how these parts are relating to this experience, this systemic experience of pain. Um, and that, yeah, that labeling it or judging it, or trying to explain it to them in any kind of medical way might not be helpful for the system, and that actually to just deeply listen to their system's experience of the pain and all the parts that relate to it is kind of going to, even if it's not going to ever remove the pain, it's just going to allow the person to have a different perspective, to relate to it differently, and that is where the shifts might start to happen. And I'm also hearing that there's this layer as well, which you're saying is really helpful for people, is sort of updating them. This is what pain actually is. So that the beliefs they have about it are actually maybe what is making it worse. And that if we can let them know the neuroscience, if we can let them know a different perspective, that somehow is also relieving. Yeah, would you say more about that, or does that sound like
Yeah,
that's kind
yeah.
of on it?
I think
Yeah.
lovely to the course that you might have been like me after I first came across it. I was like, oh wow. And then it's so much more difficult to actually communicate the concepts with patients. And I still stuff up, I still get it wrong and think, oh gosh, that person, I've accidentally invalidated them. So I think one concept I find really helpful is starting off with a kind of coming to the meaning of what's happening together, like so that somebody feels like really understood and where they're coming from. And then it really takes a lot of experimentation as a therapist to drop in little messages. And that's where I like to send people off to look at my pain modules, because it just saves a whole lot of time and lets me know who's kind of open to hearing that. So they're starting off on the same page and is important. I love the way that the first part of what you said, Ollie. And one thing that just came to me within that is when you said the pain mightn't go. One thing that's really common in IFS is the noticing the shifting of the pain. So if
Mm.
somebody finds that their pain shifts, like my client yesterday, it's like that's telling them something, because if it's something concrete in the jaw that's causing it, well, why would the pain shift? So just that felt sense of, not a cognitive thing, but a felt sense of the pain can change. So yeah, maybe there is a tissue element. I'm a bit bolshy about that. Like I really am at the extreme end of thinking most chronic pain doesn't have much of a tissue element, but I try not to be too much like that because it puts people off. But yeah, if mindfulness or self-compassion or IFS reduces the pain for a time, what's going on there, you know? That's curious, isn't it? That gives you some information.
Yeah. Very context, you're really contextualizing the experience moment to moment and curiosity and tracking. Yeah, wonderful. I think we're coming towards the end of our time with you, Adele, but there is a couple more questions. Ollie, would you like to?
Yeah. We always ask people this question, but yeah, is there anything that we wish you wish we'd asked you about, and yeah, what would that be, and how would you answer? Is there anything you feel we missed that you'd like?
Maybe with reflecting on this, I was really doing, yeah, again, I'm not as maybe as self-reflective as would be good. On me personally, on perhaps not so much the pain, but the IFS aspect. Because this was just last night when I was thinking about doing this, I was thinking when I first went into mindfulness, it came out of a part of me that just wanted some goddamn peace and quiet. Like it was all about peace, withdrawing from the world, I must relax. I shouldn't be stressed. And even as an MBSR teacher, I'm not particularly proud to say, I think I'm still in that, even though I was teaching otherwise. I think what IFS has done is I think I pointed to this right at the very start, is just this more acceptance of parts like my workaholic part, that part that wants to fix. Uh, there was a lot of shame about I am not domestic, like I don't cook, clean, wash, any of those things, and I'm not what you would say a traditional mother. Um, and you can probably hear with the amount of stuff that I do that I don't. But so if there's any shame that comes in, it's around my lack in my personal life. But what IFS has just so helped is like just be kinder to that and recognize it as a part that came from really good reasons. And just this whole, I don't know, just this whole softening and acceptance of myself and my son, who's probably suffered from some of those sorts of issues because he's my son, and with all his issues, and all my beautiful patients and all the people that I meet in the IFS community and the mindfulness and the self-compassion field, and just that, like, I don't know, just so much more acceptance of everybody's parts, and forgiveness and self-forgiveness and that sort of stuff. That's probably the thing I wanted to also say. Yeah.
Yeah, really appreciate you naming that. And yeah, I've had that experience too of that's part of this journey of moving towards just fully accepting, yeah, every part of myself. And I think that's a gift of IFS and some of those other approaches you mentioned, is yeah, that it's not about removing our experience or never having pain again or never being anxious again or never drinking again. It's actually, how can we deeply relate to ourselves with that compassion, with that understanding, with that forgiveness, and that is what makes the shift, that it's this new way of relating to ourselves. Yeah, and what I didn't realize, and it's been a gift of this interview, is that pain is similar, that it's the relationship to it. Yeah, rather than trying to stop it or trying to have it go away, or yeah, which again is similar to those old ways of thinking about mental health as well, of getting rid of your anxiety or getting rid of your depression, or whereas it's about listening to it. What is it trying to tell you? Where is it coming from? What is it related to in your life? So I really appreciate that, Adele. It's something deep has shifted in me. I haven't done one of your courses. I've just read a little bit from your website and things. So it's been a real, I can feel the beliefs that I had are shifting in just sitting with you and hearing from you. So thank you. It's really important. I'm so glad we've had this time together. Yeah.
Hey.
Yeah.
Actually, I just thought of one more thing that you people listening to this might like. I have got the PESI talk that I did on IFS and pain on my website, so on the health professionals resources part of my website, that you can access that talk. That might be for IFS therapists. Yeah.
Yeah. There was many things that I took away from your course, Adele, and it has reinforced it. Just, this interview today, just hearing you again. And the one thing that really that was in my system after doing your course is pain, whether it's emotional, whether it's physical, whether it's spiritual. That we do what we do with pain, so we find a way to be with it in however a little drop, however way we're able to.
Love
and
that.
That's the spirit. Yeah. And just to really honour what you share with us just now, Adele, also just you welcoming all of your parts in your whole system, in your bigger system as well, with your children, family. Just want to offer, I want to ask you a few questions about you and really get to know some of your parts in a very fun, playful way. And what we term is IFS Fast and Furious. Will you be open to playing this game with us?
Yes.
Okay. So don't think about it. Just from your gut instinct, see what comes up. Okay. The most endearing managerial activity.
Meditating.
Your most favourite firefighter activity.
Sleeping.
Okay. An exile gift that you have reclaimed.
I talk about my clear-eyed 14-year-old. I won't go into details. Yeah.
What is important to you now, Adele?
To keep opening and to keep exploring and to not end my life with regrets. I'm going, to open rather than to how I spent the first part of my life, which was so blinkered and closed-minded. So just to keep opening and opening. Yeah.
And what legacy gift do you wish to leave behind?
Maybe my link between the mindfulness, IFS and pain. Yeah.
And final question, which historical figure would you like to invite to dinner and why?
What comes to me is, this is really dark, but one of my pedophile ancestors, to find out what the hell. That's just what popped into my head. I do not know where that came from. Yeah.
Yeah. Greater understanding. Yeah.
Well, Adele, it's been enlightening and enlivening, and has really shifted things for me. And I'm gonna have to do some processing and reflecting in my own system about a few different things in my own experience of pain. Because because I came from a family, I think, that tried to deny that pain existed. And, when we were kids, we were told to, as soon as you would physically hurt yourself, to just get up, brush it off, keep moving. And there was nearly a belief system in the family of that pain doesn't happen, and that you've got to be fearless and you've just got to kind of move forward. So many layers, and really appreciate the depth of your sharing and your teachings, and I look forward to learning more from you. So thank you so much for coming on today and sharing with us. Really appreciate it.
Oh, thank you. It's been an absolute pleasure. Thank you very much.
Yeah. Thank you, Adele, for all that you offer and bring to this world. I look forward to tracking your work. So.
Thank you.
Yeah.